questions, and also that Dr. Smith can too. So I want to welcome everyone to Hope Connections educational program tonight, Understanding and Treating Peripheral Neuropathy with Dr. Thomas Smith. Dr. Smith is a professor of oncology at the Johns Hopkins University School of Medicine, director of palliative medicine for Johns Hopkins Medicine, and the Harry J. Duffy Family Professor of Palliative Care. He is a medical oncologist and a palliative care specialist with a lifelong interest in better symptom management, communication, and improving access to high-quality, affordable care. Dr. Smith began Johns Hopkins hospital-wide palliative care consult service, as well as an inpatient unit, and he is dedicated to accelerating palliative care research and education. Dr. Smith is a fellow in the American College of Physicians, the American Society of Clinical Oncology, and the American Association of Hospice and Palliative Medicine, and is listed among the top oncologists and palliative care specialists in the country. He has taught palliative concepts in more than a dozen countries and helped start over 100 new programs. Dr. Smith received his medical degree from Yale Medical School and completed his residency at the University of Pennsylvania and a fellowship in oncology and hematology at the Virginia Commonwealth University School of Medicine. He joined the faculty at Johns Hopkins in 2011. Dr. Smith, we're thrilled to have you here with us tonight, and I'm going to turn the program over to you.
Well, thanks, Stephanie. The only thing that gives me street cred probably is the fact that I'm a cancer survivor myself, living with metastatic cancer. So for all of those of you who know what it's like just waiting for the other shoe to drop, I feel for you, because I'm with you. I've spent the last 35 to 40 years being an oncologist, and about 20 years ago, got really interested in wondering why oncologists don't pay more attention to people's symptoms, like pain, nausea, depression, anxiety. I see a lot of heads nodding. Let me apologize in advance for all oncologists. I think one of the old beat poets, John Berryman, had a quote that most men are sleepwalkers, not evildoers. And I think that's the way it is for most physicians. If we had a better, simpler, easier way, we would hopefully do the right thing. Maybe I could just jump right into my slides if I can switch here, share my screen. Right. Is that saying neuropathic pain with an emphasis on chemoneuropathy? That's it? Okay, I'm gonna move my camera over to this screen, so if I can, if I can't. So I put my contact information in there. There are some things you may want to contact me about, particularly clinical trials we're running. My advice to you as patients like myself is you partner with a healthcare professional who will listen to you and work with you over time to do multiple trials of medications. There's no perfect drug for a lot of things in oncology. Nausea, appetite stimulation, and chemotherapy-induced neuropathy is one of those things where when we redid the national guidelines for the American Society of Clinical Oncology last year, there really wasn't a whole lot that we could recommend with enthusiasm. You also have to figure out how to do trials of medications. If one thing doesn't work, don't just say, well, I'm gonna have to live with this for the rest of my life, because there are some options 2 and options 3 and options 4 sometimes that might work for individuals, but just haven't been tested very well yet. When I talk to providers, I tell docs to take this seriously. If you have chemo-induced neuropathy, it can be not only peripheral, but it can be your autonomic nervous system. So your heart rate, your control of your gut, control of your blood pressure, all those things can be affected too. And one of my friends followed 500 some patients at the University of Rochester and found that if you had chemotherapy neuropathy at the end of treatment, about 50% of people would still have it 6 years later. And if those people who still had chemoneuropathy, the risk of serious falls was nearly doubled. And if you're old like me, I'm close to 70, you really don't want to fall and break your elbow or break your nose or hit your forehead. The other thing I tell providers is do not start with gabapentin. It is not a good drug for chemo-induced neuropathy unless it happens to work for you. It probably works in one out of a dozen people. Do use or start with duloxetine or Cymbalta. It's the only drug so far known in randomized double-blind placebo-controlled trials to reduce the pain of chemo-induced neuropathy. Topical menthol has never killed anybody that I know. If you have cats, they'll love you because they'll be licking your toes and your fingers wherever you put this stuff on. I suggest mineral ice, which you can get at any drugstore. For those of us at a certain age, it looks a little bit like the hair gel Dippity-Doo. It's sort of a bluish color and comes in an 8-ounce or 16-ounce jar. I'll show you the data. And you have to be willing to do a couple different trials of medicines. If something doesn't work in 2 or 3 weeks, it's not going to work in 8 weeks. So if something isn't working in 2 or 3 weeks, talk to your healthcare professionals. Probably, frankly, if your office has an advanced practice nurse or nurse practitioner, they're probably better at it than the oncologist, and try to do something else if something isn't working. Mindfulness or meditation doesn't fix your nerves, but it can fix how your brain adapts to it. Because every time I have a symptom related to my cancer, it goes straight zooming through my brain. It starts rolling around in there, bouncing back and forth, puts me right back into the PTSD of, hey, I have cancer. Hey, my future is uncertain. Maybe tomorrow will be better, but chances are it won't be. It'll be just as bad as today. And it puts you down this rabbit hole. And mindfulness and meditation can really help you notice those thoughts, not pay attention to them, go back to concentrating on your breathing, and calm your inner self down. I personally use the Calm app, C-A-L-M. I found that very helpful, particularly during chemotherapy and radiation and after surgery. Yoga does the same thing. You can show that people's brain waves normalize, and both mindfulness and meditation and yoga seem to improve people's memory. I've heard of this stuff called chemo brain, where you don't remember stuff. And at least in a couple of experiments where people have either started right with mindfulness or yoga and then waited 12 weeks, the other group waited 12 weeks and started it, there's about a 25% increase in short-term memory, which I could really use. Exercise is good for everything. Slashes your bowels around, gets your lungs moving, gets your brain moving, gets you in the outside world, keeps you connected. People are less depressed and less anxious. And if you can't get your oncologist interested in fixing your chemo-induced neuropathy, palliative healthcare professionals might be a good fit, particularly if they have a specific interest in it. Let me just define what palliative care is. Palliative care doesn't kill people. People with mustaches kill people. Palliative care is specialized medical care to relieve the pain, stress of serious illness, whatever the diagnosis. We see everybody who gets a heart transplant. We see everybody who gets an artificial heart. And we're in there urging people to be cured if it's possible, just providing that extra layer of support. That's Diane Meyer's definition, which is pretty long. I just say it's expert symptom assessment and management, open and honest communication, and medically appropriate goal setting. What's possible and what isn't possible. So the reason to emphasize symptom management is because symptoms kill. That's right, symptoms kill. This is 766 patients from Sloan Kettering with advanced cancer who were randomized to two groups. One group got their usual care at Sloan Kettering, which is terrific. The other group got their usual care plus an iPhone or a computer entry system if they didn't have an iPhone or a smartphone. And once a week, they reported their symptoms. So on your iPhone, a word cloud would pop up with shortness of breath, constipation, diarrhea, depression, anxiety. You could press on it and then move it on a scale. And if the scale jumped like that, there was a nurse at the other end who was on 24 hours a day who noticed it, picked up the phone and called you and either fixed it over the phone or brought you in. And this is 6 people out of 100 alive. It's an average of 6 months longer survival. And who wouldn't want to live 6 more months with better symptom management? And it's an absolute difference of 6 out of 100 people. That's a lot more than some of these new drugs we're talking about at $14,000 a month. All right, so I'll stop proselytizing about palliative care and go on to neuropathic pain syndromes. It's not just chemo, it's post-radiation pain, post-surgical pain. People get phantom limb pain, where I've had this big, tough Marine look at me and say, you know, they took my leg off and no, I don't have a right leg. I'm looking down there, there's no leg, but it feels like somebody has hot vice grips on my big toe and on my Achilles tendon, and I think I'm going crazy. He's not going crazy, he's got phantom limb pain. I'll show you some things about post-mastectomy syndrome. That's when you have pain that recurs after you've had your radiation and chemo or had the mastectomy. If you ask oncology surgeons, oh, it's just a few percent. If you ask women, it's more like 25% of people have significant pain. Same with post-thoracotomy. If you had a piece of lung taken out, I hope all of you who are eligible have had the shingles vaccine. Shingles is an SOB. The older we are, the more likely we are to get post-herpetic neuralgia or post-herpetic neuropathy, where it just continues to hurt like somebody had a burned-somatic torch on those nerve endings. And then, of course, chemo-induced neuropathy. So it's not just that. Chemoneuropathy is the bane of my existence as a breast cancer doctor. I've probably produced more than I ever care to admit. I didn't recognize it until too late. It's become the new dose-limiting factor. Sometimes doctors and nurses will say, well, if you haven't had it by the time you finish treatment, you're not going to get it. Turns out to be wrong. About 20 to 25% of people don't get any neuropathy until after their treatment. And then it's too late to reduce the dose or change the schedule. It can persist for 6 years, 10 years, 20 years. Pain and suffering, your fall risk is twice as high. And again, it's an everyday reminder of a cancer-related PTSD. You put your feet down on the floor in the morning and they hurt, or they hurt and they're numb and they tingle. And it's, what? Why do they do that? Because I had cancer. Oh, that reminds me, I got chemotherapy. And it just puts you right down in this spiral that you don't want to be there. So what works for prevention? We don't know. Nothing so far. Absolutely nothing. There's one small trial done in Tehran where half of 60 breast cancer patients were given big doses of fish oil, and it seemed to prevent it a little bit. The University of New Mexico has finished a much larger trial trying to answer the question, and they haven't published it yet, so I think it's going to be negative. I think if it was positive, the results would have come out a year and a half ago. Exercise may help prevent it. People who exercise during chemotherapy have a little bit less pain on a scale of 0 to 10. The average benefit is about 1/4 of a point, so it's not huge. But with all the other benefits of exercise for your brain, for your psyche, for your lungs, for your gut, you should do it. There's another calmangofluticapir. It's an infusion that protects your mitochondria given before oxaliplatin. And it was done in, Bert Glamelius did a small study in Sweden and it seemed to work. One big important thing is it didn't allow the cancer to grow. You don't want something that protects your nerves, but protects your cancer. You got to remember that the whole goal of taking chemotherapy is to get rid of cancer. So it didn't do that. It didn't allow the cancer to grow, but it didn't quite meet its approval. So it's being tested in a much larger phase 3 trial. That may be out in the next 6 months or so. I would hope so. So that it only works for oxaliplatin, which is something used for rectal cancer and colon cancer. It doesn't work for Taxol and these other things. You may have heard about cooling gels and slippers. You may have even had people order them from online. So you can order on Amazon.com these hypothermia cooling slippers and these gloves that you stick in the freezer, and 15 minutes before you get your chemotherapy, you stick your hands in them, and you stick your feet in them, and then half an hour later, before they warm up, you get the other pair out of the ice chest and put your hands in those. It's really, really uncomfortable. The first trial was done in Japan, and it really seemed to work. The incidence of serious chemoneuropathy went from 81% down to 28% in the hands and down to 25% in the feet. So this looked really promising. And this graph just shows the light blue there. When people had, you put 1 foot in and 1 foot out, sort of like doing the hokey pokey. The foot that got warm had more neuropathy. The foot that was cold and the hands that were cold, half of them had no neuropathy at all. So this looked really exciting. And then my friend Judy Pace, who runs the pain program at Northwestern, tried to do this in Chicago. And Chicagoans are used to the cold, right? They're not wimps. 29% were randomized to do one hand and 1 foot, the other one just normal. 34% couldn't tolerate even the first day. 6 more stopped during the study. Only 7 people completed the study, and there was absolutely no difference between the 2 arms. And the Mayo Clinic did a much larger study with 50 people, and there was no difference between the group that got their hands and feet cooled down and the group and the hands and feet that didn't get cooled down. My wife did part of her medical school in Japan back in the mid-70s, and I've worked over there for some time. And I can tell you that at least in medicine, it's still a male-dominated society, and Japanese women do what the doctor tells them to. I hope I don't offend anybody by saying that, but I think the Japanese women put up with incredibly cold hands and feet that American women simply didn't do. Or maybe there's something specific about genes and society that we don't know about, but we really couldn't recommend this as something for prevention. So what works if you have chemo-induced peripheral neuropathy or painful neuropathy? There are a lot more things that don't work, that have been proven not to work, that I still see people on. One is glutamine. Another is lamictal or lamotrigine. It's often used for headaches. Gabapentin or Neurontin did not work any better than placebo in the really large randomized controlled trial. And yet I continue to see my colleagues put people on gabapentin because it does work for other nerve things. It works a little bit for shingles. It works a little bit for diabetic neuropathy. Not very well, but it works a little bit. And they don't know about duloxetine, so they write gabapentin and often don't maximize the dose. Vitamin E does not work, and actually, if in large trials, it increases the risk of bleeding into the brain. It unclots your blood, so don't take vitamin E at large doses. Nortriptyline and amitriptyline antidepressants don't seem to work by themselves. Alpha-linoleic acid works in diabetic neuropathy, but it may actually make chemoneuropathy worse, and it had no protective effect. Acetyl L-carnitine in the one randomized trial, the group that got the active drug versus the placebo, did worse. Vitamins, including megadoses of vitamin B12, Again, they seem to work a little bit in Japan and China, but they haven't worked in the US and Europe. So there's really nothing on this list, all of which I see commonly used, that is helpful. On the other hand, if you've been on gabapentin and your doctors, I see you in the clinic and say, well, it really doesn't work. Why don't you try going off it? And if you go off it and your pain gets worse, it's probably working for you. And that's the only way you'll find out. So each of these drugs may work in 1 out of 12 people. And you're never going to find that in a randomized controlled trial. So don't give up on drugs, but just use them judiciously. Here's this data on duloxetine, Cymbalta. It works for a lot of things. It works for knee arthritis, actually. It works for depression pretty well. Works for chronic fatigue syndrome. And in the first 6-week period, she randomized people to get duloxetine or placebo. And you can see here the duloxetine, their scores were down by about a point. Then there was a 2-week washout period where people didn't take anything. And then if you'd been on placebo, you switched over to duloxetine. And you can see the duloxetine again was about a point lower. So you start with 30 milligrams a day, then go up to 60 milligrams a day. It's not a terrible drug to take. In fact, it might help depression. It might help you sleep. It might help with some other things. But 11% dropped out due to adverse effects, usually nausea, dizziness, and fatigue. It doesn't change the damaged nerve endings. What happens with chemoneuropathy is it damages the longest tips of your nerves. That little nerve ending right there, for that little speck, actually starts way back by my spinal cord. And it's like somebody took a little piece of silly putty and stretched it way, way, way out. And that little tiny fiber has to go all the way from my spinal cord back to here. These drugs don't affect the damage to the ends of those nerves at all. What they do is they change your brain chemistry. They're antidepressants, after all. They raise your levels of norepinephrine and serotonin and may prevent some of the pain impulses getting to your brain. Again, it's not a great drug, but it's an okay drug. One thing that wasn't emphasized in the paper is it doesn't help with numbness and tingling. You would think, well, if I have pain, why the heck do I have numbness? And if I have numbness, why the heck do I have pain? Aren't those completely opposite? And the answer is they are opposites as we think about them, but they're not opposites to your nervous system. So pain is pain. You've got pain nerves. You've got at least 3 or 4 different types of pain nerves. That something's damaged out here, you stick a pin in it, you stick it on a match, it hurts, it sends the impulse up to your brain, you pull your hand away almost before you know it. Those are typically your C fibers, and there's not going to be a quiz at the end of this. Those are your C fibers that carry pain. The numbness, tingling, burning sensations, cold sensations, those aren't damage to your pain nerves. Those are damage to your itch nerves, your cold nerves, your heat sensitivity nerves, your deep pressure nerves, your light pressure nerves, and probably a bunch more that we don't know about. So when those nerves get damaged, they keep sending these weird signals up to your brain that your brain interprets as numbness and tingling, like walking on gravel or walking on sand. Or somebody said, it feels like my feet are wrapped in wet rags all the time. Or I just can't feel them. I'm afraid if I close my eyes and don't have any clues to where I am, I'm just going to fall down. That's not the opposite of pain, that numbness. Those are abnormal nerve endings coming up from damaged nerves in your feet. What works for it? There's one topical agent that works a little bit that is not as widely used or recognized as it should be, and that's BAK gel. That's why I put my contact information if you want the recipe. If you've got a good pound cake recipe, I'll trade it for you. Just teasing. But Deb Barton was the head of nursing research at Mayo Clinic, and she and my friend Charles Liprinzi did a study where they took this baclofen, which is an antispasm agent, amitriptyline, which is the oldest antidepressant, and ketamine, known in the street as Special K. used for anesthesia, they made a gel up about 1% of each of these. And they took a teaspoon and they rubbed it all over the hands of, people either got placebo or the active gel. They rubbed it all over their hands. They took another teaspoon, rubbed it on the right foot, took another teaspoon, rubbed it on the left foot. Because it's always the bottoms of your feet and it's always the tips of your fingers that get it the most. And it really did seem to help the hands a significant amount. It helped with things like writing, eating, picking stuff up, not dropping stuff, not dropping your favorite mug. It helps things like that. It didn't seem to work very much on the feet. And there are a couple of reasons for that. One is when you're putting it on your hands first, and then you're putting it on in your hand to rub it on the feet, your hands are getting a double dose. So Deb Barton was going to do a much stronger concentration, a 4% concentration. But then she got hijacked to the University of Michigan to head the nursing department there and has stopped doing this sort of research, which is a real shame. It'll cost you about $60 for a month's supply. Ketamine price jumped way up a year ago and then it's back down again. But you can try it for a month or 6 weeks. It almost can't hurt you. Very little of it's absorbed into the blood, so it's not going to affect your brain at all. Not like duloxetine or some of these other things. It has to come from a compounded pharmacy. Nobody makes it commercially. The other thing that works is menthol. And I send people to the drugstore to get mineral ice. One of my colleagues, Marie Fallon, who's an oncologist and neurologist in Scotland, had 2 patients come in to see her over the space of about 6 months. And I wish I could do a bad Scottish accent, but they said, "Dr. Fallon, you tried to kill me with that chemotherapy. And, I started putting Dermacool on my hands and feet, and they're a lot better, and I'm ready for more chemotherapy." And Dermacool is 1% menthol. And it's dirt cheap in the US. You can order it on Amazon.com, but it's really expensive. So get mineral ice, which is 2%. It'll be about $16 for a 16-ounce jar, which is more than enough for a month. So you rub a teaspoon on your hands, and then you rub a teaspoon on your right foot, and rub a teaspoon on your left foot. You rub it as far as the neuropathy goes in. And it sends a cooling, non-pain signal along those damaged pathways. It actually hits your itch receptors and some of your cold receptors out there. So it actually is binding to those nerves and sending this alternative to ow, 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 ow. It's cool, calm, soothing. And what she saw was 82%, 31 out of 38, had significant improvements in their pain scores, including big improvements in walking, sleeping, and this lovely English word, catastrophizing. That's where you get up in the morning and you put your feet down and your feet hurt, and you say, "Darn, my feet hurt. They hurt yesterday. They hurt when I went to bed. Today's gonna suck too, just like yesterday did." That's my official definition. One thing she wasn't expecting was that people who have chemo-induced neuropathy, their nerves are actually hypersensitive. They're hypersensitive to touch, they're hypersensitive to cold, hypersensitive to pressure and heat, as marked in the red stripes here. And after 6 weeks of putting this on, the area of hypersensitivity really, really, really shrank down. So it's doing something to heal those nerves. It'll cost you $16 for a month's supply. It's well worth it. I mean, it may not make it disappear, but if it takes your pain score from an 8 down to a 5, I'll be happy. And it may actually help the numbness and the tingling too. All right. I wish I could see all of you and have you raise your hands, because I would ask, how many of you have had your oncologist say, drugs like oxycodone and morphine have no place in treating chemoneuropathy. They don't work for nerve pain. Turns out to be completely bogus. This has been taught for 100 years, that opioids don't work for nerve pain. But the answer is that they actually do. I saw somebody today with terrible, terrible chemoneuropathy from myeloma. And what has made her functional is having some 5 milligram oxycodone tablets, the smallest dose you can get, and taking an extended release, tiny dose in the morning and again at night. And it's made her go from somebody who really hated to put her feet down on the ground to somebody who can take a walk with the dog. And that's the only intervention that's worked for her. So Ian Gilron, bless his heart, studies drugs that are generic, so nobody's going to make any money on them. And he's had a real interest in treating nerve pain. These are not chemoneuropathy patients, but they're patients with shingles neuropathy, diabetic neuropathy. You can see their baseline scores started out at about 6. The group that got placebo for the first month, their scores went down a little bit. So there's probably some placebo effect to it. Also, when you go on these sorts of trials, you go on because your symptoms are unbearable. So your symptoms are at their worst and they're going to get better a little bit anyway. Gabapentin helped a little tiny bit more than placebo. Morphine actually helped more than gabapentin. And what's interesting was that the combination is synergistic. So they could cut their pain scores from 6 down to 3.5 by taking a combination of morphine and gabapentin. Either one by itself is not probably going to do the trick. You really need that combination. Combo is always better. This is where you need a willing healthcare professional partner to work with you on this. He did the same thing with one of the oldest antidepressants called nortriptyline, morphine and nortriptyline. Here's the baseline up at 5.5. Here's morphine. I mean, it dropped the pain scores by 1.5 points, almost 2 points. Nortriptyline dropped it a little bit more, but again, the combination was better than either one alone. These are not chemoneuropathy patients. There aren't any other good studies you can point to for chemoneuropathy patients, but in my own practice, these are the things that I go to when duloxetine doesn't help. And these things may help with the numbness and tingling too. So you do 2 or 3 week trials. Here's a very complicated one. What he did was he gave people gabapentin by itself, nortriptyline by itself, or the combination. So nortriptyline is an antidepressant, raises your norepinephrine and serotonin levels in your brain. Gabapentin works on a chemical called GABA in the brain, so it works differently. And you can see this blue or dark turquoise line is the combination. It's always better. And this is day 15. So you don't have to wait 2 months to see if something's going to work. You can tell if it's going to work in 15 or 20 days max. So if you're talking with your oncologist, you're starting a new drug for neuropathic pain, say, I want to contact you in 3 weeks and tell you whether this is working or not. If it's not working, we need to do something different. The one thing that Dr. Gilron did differently from most oncologists was he didn't give you gabapentin until you got side effects from it and then add nortriptyline. What he did was he started with low doses of both and escalated both at the same time. So that's a new trick that your pain manager is going to have to learn, because that's not the way we usually do stuff. We usually do one drug and then add another drug and then add another drug. But he used both at the same time, and it really seemed to work. These pain scores dropped from 5 down to 2. It's rare that you're going to get any sort of pain down to 0. You don't need to. Charlie Cleland and his wife, Shelley Wang at the MD Anderson Cancer Center looked at people's pain scores and found that you only need to get down to about 4 to lead a pretty normal life. At 5 and 6, you're thinking mostly about pain. At 7, 8, 9, 10, all you're thinking about is pain. You're not thinking about your grandkids. You're not thinking about your dog. You're just maybe even thinking about when's your next dose of pain medicine. All right. Thinking outside the pill box, what might work? Acupuncture. People could raise their hands if they've had acupuncture. It's very dependent on the person who's getting it, the person who's doing it, what sites you use. We really couldn't find, when we looked at all the evidence, enough evidence to say that it really worked very well. There's just as many negative studies as there are positive studies for it. It can't hurt you except your wallet. You know, Medicare doesn't pay for it. Very few insurers pay for it. So you're paying it out of pocket, but you can try it for 2 weeks or a month and see if it helps. I've had some patients benefit from it. Nobody that I know has ever gotten harmed by it, except again in the Wallet book. I'll show you scrambler therapy, and I'll show you ear or auricular acupressure and neurobiofeedback. These are my feet and hands set up to treat chemo-induced neuropathy with something called scrambler therapy. Most of you have either heard of or seen somebody or know somebody who's used a TENS unit, transcutaneous electrical nerve stimulation. I mean, Shaq was advertising them on TV with the Gold Bond brand, and they're like 20 or 30 bucks. You put electrodes on the area that hurts, run this current through it. The problem is it doesn't work very well, if at all. And as soon as you take the electrodes off, the pain relief goes away. So it's not an effective way of treating chemo-induced neuropathy. This machine looks superficially like a TENS unit, but it's called scrambler therapy. And what it does is it feeds in artificial nerve impulses. So if you hooked it up to an oscilloscope, it would look like this. For those of you who are healthcare professionals, that looks like a very abnormal heart rhythm that you want to go get the paddles and shock somebody out of. But what the inventor did was he made it to look like how one nerve talks to another. So how this little dinky nerve out here talks to the nerve in the spinal cord that takes a message up to the brain in the thalamus and then takes it up to the pain center. These are the little electrical action potentials or electrical currents that nerves use to talk to one another. And it's basically 5 sets of artificial nerves that send this non-pain information along your normal pathways. And it scrambles the signal and may allow the nerves to and brain to reset. Here's an example of someone that's still under treatment with me. She had chemotherapy in September 2018. So what, 3.5 years ago, 4 years ago. So the bottom of the foot is the 5th lumbar nerve. The side of it is the 1st sacral nerve. The inside is the 4th lumbar nerve. Her pain was down here, but I started touching her up here and she said, well, Dr. Smith, I don't want you to imply that you're getting fresh, but it's my feet that are hurting, and why are you touching me on the thigh? And if what I did was, I touched her on the thigh up here and said, is that normal? And then worked my way down about once every inch. And she said, oh, right there, it changes. It doesn't hurt there, but I can't feel that very well. Look about 4 inches below her knee. That's where her neuropathy went all the way up to, even though she only felt symptoms on her feet. So you have to put the electrodes on normal tissue, and then it sends that signal you saw through that little ellipse of skin and basically sends a non-pain fooling message up to the brain and lets it reset. You can see day 1, her pain went from 8 down to 3. Then she had some family things to do and Thanksgiving, etc. Came back in on a couple weeks later, her pain was 3. It went down essentially to 0. And then a couple days later, it come back up to 3, went down to 2. And she's now out here in February, and her pain is still about a 1 or a 2 with just 4 or 5 treatments. I haven't gotten her to 0 yet, but she's just happy to be able to walk without her feet hurting all the time and to be able to go hike and things like that. There's another person who had taxol neuropathy 7 months prior. Again, her pain was down in her feet, and she had numbness and tingling and pain in her fingers and her hands. So I'm catching the nerves up here and sending that impulse up to the brain, up to the spinal cord, up to the brain. Pain went from 5 to 3, came back up to 4 the next day, went down to 0. And here she is a 1.5 years later, still living at pain score of 1 or 2. And that's pretty typical for the results we get in about 60% of people. We've recently published this randomized trial with our colleagues at Mayo. And what we found was that pain scores went down by about 60%, 60%. And it actually works for a little bit for numbness and tingling. So let's say you got oxaliplatin for colon cancer and what you have is numbness and tingling. it was about a 40%, 45% drop in numbness and tingling. So it's a bonus that it works there at all. The problem is it's not readily available. There's no way doctors can make money at this, the way it's reimbursed. So people, pain managers who like to make a lot of money aren't really interested in it. But if you Google scrambler therapy near me or scrambler therapy centers, you might find one that's close to you. This is a person who had a benign form of cancer, a benign form of cancer. That's something called schwannomatosis, where this nerve has made a big growth right there, and she's got another one right up in here. So she's got one pain up in here, one pain up in there. I just put the electrodes across the area of pain, and she went from limping into the office, barely able to move, with a pain of 6 down to a pain of 1.5. By day 4, she was essentially pain-free. That night she cooked dinner and she slept through the night for the first time in about 2 years without pain. And on day 6, she went skiing with her family. So I would consider that a success. Post-mastectomy pain. It's a real thing. It's got its own ICD-9 code. This woman said, it feels like I'm wearing a barbed wire bra all the time. So it's sending that current. It feels to me like being bitten by electrical ants. Her pain went from 8 down to 2. These are daily treatments. Came back 3 months later, only took 2 treatments, and then her pain stayed at 1 or 2 up until she died 2 years later. So she was back at painting. She was back leading a pretty normal life. Most recently, we've treated somebody with amyloidosis who's had chemo-induced neuropathy. You can see what her pain scores did. They went from 4 to 3 to 2. And then after each treatment, they went down to 0. A month later, it came back and it went back to 0 again. She's now out 6 to 8 months, and her pain scores are again close to 0. She can sleep through the night. She can allow the covers to touch her feet and hands. So that's pretty exciting. Refractory post-herpetic neuropathy. We did 10 patients. I did 2 here in the States, and the inventor did 8 in Rome. And we saw the pain scores go down by 95% just by putting the electrodes across the area where the shingles was. So it seems to work really, really well like that. It sometimes seems like shooting fish in a barrel. We most recently been branching out to treat painful bone metastases. This poor guy, you can see his shoulder here looks sort of moth-eaten because the lung cancer has really bitten away most of the bone there. So he couldn't raise his arm, and of course he's right-handed, so he couldn't eat, he couldn't write, he couldn't pick up anything. Every time he moved his arm, it had this excruciating pain. And he actually got just a total of 4 treatments, and his pain stayed really nicely controlled until he died about 50 days later in hospice. We've started treating bone and visceral metastases, and it's the same thing. This is where it's most common in Italy because it was invented there, and 100% of patients got a pain relief of greater than 50% or more, 100%. So that's pretty exciting. We've also branched out to Parkinson's disease. I mean, as a cancer doctor, I was amazed to find that people still had other serious illnesses. I mean, who knew people were still dying of heart disease and Parkinson's? But this guy had excruciating pain for 4 years. We gave him 3 treatments. He is now pain-free, has been pain-free for 4 months. He's happy as a clam because he can sleep through the night and doesn't have to take any pain medicines. This woman had trigeminal neuralgia from a tiny, tiny stroke in her brain. And within this area of her cheek, she couldn't stand anything to touch it. It just burned like fire. That's the hallmark of nerve pain. And within 15 minutes, she's pressing her cheek like this, saying, "What the heck did you do to me?" And the answer is nothing fancy, just scrambler therapy. And her pain stayed away after 2 treatments. So I talked a little bit about neurobiofeedback being promising. This is Sarah Prinslew's work at the MD Anderson Cancer Center. She has people look at a computer screen and solve a puzzle. So they're getting their brain working on solving the puzzle rather than on concentrating on their pain. And they try to get where you can turn the entire computer screen blue and then hold it for as long as you can. And you can look at the pain scores here. You can see the pain scores went from 6 down to 3, stayed there, and only came back up after a little bit of 4 months. So it's a 3-month treatment. They came up a little bit. So she's replicating the study in a much larger population, but it could be that by just putting electrodes on the surface of your scalp and having you concentrate on something as a form of advanced meditation, that you can actually reverse some pain impulses. This is the other exciting project we're working on, which is ear point acupressure. These little sticky pieces of tape have little Chinese flower seeds behind them. And you put them on specific spots in the ear. And my friend Chao Sing Ye at the School of Nursing says, this is where the legs are, this is where the arms are, this is where your sympathetic nervous system is inside there. This is your thinking part of your brain. This is your speech center. And I was probably rolling my eyes when she was telling me about this, thinking, oh geez, another crazy Chinese medicine with no proof to it. But we decided that we would try to see if it worked and see if we could prove how it worked. So we took 15 very brave people with chemo-induced peripheral neuropathy, and we put these little sticky pieces of tape on their ear, and then you press them, pulse pressure, for 3 minutes, 3 times a day. And she has a little app on that reminds you to do it. So you pulse pressure them for 3 minutes, 3 times a day. I can tell you that 45 minutes after I did my first therapy, I felt like going down to the gym because my knees didn't hurt nearly as much as they used to. So it really seemed to help me. But more importantly, for the 15 patients with chemo-induced neuropathy, their pain was cut in half, their numbness was cut in half, their tingling was cut in half, and their stiffness in their joints was cut in half. Not only that, but it seemed to reset the inflammatory system. In this high pain state, there are a bunch of proteins circulating in the blood that increase inflammation. They're up. The ones that suppress inflammation are unfortunately suppressed and down. 4 weeks later, it's reversed. She's restored some balance to the inflammatory system, and that's got to be good for your brain, it's got to be good for your heart, it's got to be good for your nerves. We even had some brave souls who went into the MRI machine. You have to drug me up to get me into the MRI machine these days because I'm claustrophobic now. But within an hour after putting these on and starting the pressure, those blue areas are areas of the brain that should be talking to one another if they're going to correct pain. And within an hour and lasting at least a month, you could see that the parts of the brain that should be helping to solve pain problems are actually talking to one another. That's pretty cool, exciting evidence. Here's the data on exercise. Again, this is about 600 patients randomized to either exercise with 45 minutes of walking 5 times a week and a TheraBand, which you put around your knees and do, walk the dog exercises or pretend to be a dog on a fire hydrant, basically strengthening your hip and pelvic muscles. And the group that was the exercise group, they had a little bit less neuropathy at the end of 6 months. So that's about it. So don't ignore CIPN. It can persist. It absolutely causes demoralization. You just get sick and tired of being sick and tired, and it causes falls. So try to get somebody to help you fix it. Find somebody to partner with for treatment who will listen to you and work with you through subsequent trials. Think outside the pill box. There are some things you can do on your own. Menthol, topical menthol, the BAK gel. You can take your doctor in a recipe and ask the nurse to write it out, and maybe they'll do it. Meditation clearly works, the Calm app. I use thisiskara.com for those of you like that one. It's the UCLA Mindful Awareness Research Center. So if you Google UCLA MARC, that takes you to a site that has terrific free meditations on it. And it actually works, and it's probably good for your soul and body. Exercise, walking in these therapeutic bands, and maybe electroacupuncture or scrambler therapy, and keep tuned to nerve biofeedback. So that's all I've got. I'm open for questions.
Well, I just want to say, Dr. Smith, I mean, this is just, all the information you shared is amazing. The work you are doing is just so exciting. And I'm sure lots of people are going to have questions for you. But I also just want to thank you too for your thoughtfulness, your sensitivity, and your sense of humor. I know I appreciate it, and I think everybody here does too, that it's just so refreshing to hear a physician really, you know, kind of giving what works, what doesn't work, your knowledge, and in such a honest way. So thank you so much for that.
You're welcome. You're very welcome.
So I'm going to open it up for questions. Of course, we are. And I'm just going to the chat right now. So the first question is, do you need a prescription for the mixture, the compound that you talked about? I guess it's the BAK gel.
The BAK gel, yes, you need a prescription, particularly for the ketamine, because ketamine has a long history of being abused on the street. It's called Special K. If you take enough of it, you can think you're Superman and do crazy stuff. So if you just email me, I'll send you back the recipe. I put my email in the chat box there. It's not hard to make up, and any compounding pharmacy can make it.
Okay, great. And then somebody asked, is the Dermacool, the mineral ice, the same as Vicks Vapor Rub?
No, Vicks Vapor Rub only works for colds, and you know, Bear Grease probably works as well as Vicks Vapor Rub for colds. I'm teasing. Vicks Vapor Rub is too strong. It's about 10% menthol, which is why it smells so strong, and that's why your parents put it on you when you were young. And if you put 10% menthol, like Icy Hot or Bengay or Tiger Balm, if you put it on damaged nerves, they're going to say no thank you in a very loud and voracious way. They're going to say that hurts like heck, and don't ever do that again. And make sure, if you do use any of those, make sure you wash your hands very carefully before you go to the bathroom. Just word to the wise.
That is a good tip.
So get 1 or 2% menthol. It doesn't have to be these. Gold Bond makes a lot of creams that have 1 or 2% menthol in them. That's the active ingredient you're looking for. And it's not magic. It binds to these little receptors out here on these itch nerves and sends this cooling, soothing message back up the spinal cord to the brain, and may, like scrambler therapy, reset the whole system. But please don't use Icy Hot, Bengay, things like that. Your nerves will not thank you.
Okay. And I don't know if I'm saying this right, but where do you find, is it auricular therapy at Hopkins? AURICULAR? Auricular?
Or it's easier to say ear point acupressure.
Auricular.
Sharon Mope is our research coordinator. Probably the easiest thing is just to email me, and then I can put you in touch with her. It's not a placebo-controlled trial. It's a trial of two different ways of doing it. One is you make 4 visits here, and basically we teach you how to put them on, and then you keep them on. After about a week, they fall off. You can shower with them, and they eventually get wet and fall off, and that lets the ears reset for about a day. And then you put a second set on. The other group, we're doing all the teaching by video or by, basically by telehealth. So everybody gets treatment. And so far, it seems like both methods seem to work pretty well. It's not going to knock your socks off, probably. It's not going to make your pain go from 10 to 0 on day 1. But if it can get you from an 8 down to a 6, then down to a 4, and help a little bit with the numbness and tingling, and make it so your hands aren't so stiff, then it's a good thing. There's a drug we use for breast cancer. I'm a breast oncologist. The whole class of compounds called aromatase inhibitors that really drop your estrogen if you're postmenopausal. And the main side effect they give you is stiffness in your joints. Not frank arthritis where the joints are swollen up, but just everything feels like somebody poured cold mortar oil in them. And Chow-Sing has already done one study showing that it works for that too. So you can kill two crabs with one stone.
Okay, well, we still have a lot of questions. There are nerve support pills for sale on the internet that claim they help with neuropathy. Is that true? And are they helpful?
There are a lot of things that claim they help with neuropathy. I would say, show me the data, and the data aren't there. One of them that I looked at says, our clinical studies support our facts. What they did was they took about 150 people, gave them these devices, and then asked them to return questionnaires. Well, only about 80 out of the 150 returned the questionnaires. And you can guess who's going to return the questionnaires. It's the people who may have gotten a little bit better. So you can't trust much. For those of you who are fans of the Boscov's department store, they have a section called As Seen on TV. And I think you have to be really skeptical when you see something that says, we can fix neuropathy. I wish. There are dozens of biotech companies and universities trying to fix neuropathy because they know the first day they get FDA approval, they're going to sell $100,000. The second day, it's going to be $1 million. The next week, it's going to be $10 million in profit for them because nothing works that well. You will see an increase in scrambler therapy availability as chiropractors start doing it, and there are foreigners practitioners up north of Baltimore that are doing it, and I think doing a pretty good job of it. So you'll see that becoming more available. You see something called, somebody was telling me about it today. It's a sock. It's basically a boot or sock that you put on, called the normalizer or something like that. It does have a money back guarantee, so it costs about $1,000 to buy, but this person tried it, it didn't work, and they got their money back, less a $50 restocking fee. So.
Okay. Are there any studies that show medical marijuana helps?
Good question. The answer is maybe. The group at UC Davis has done the best job trying to figure out, can you make a mister or essentially a bong that gives you enough THC to help with the pain but not make you high? And the answer is yes, you can. It's not clear if THC, which is the active ingredient in marijuana or cannabis, whether it actually does anything to the nerve impulses or whether it just dissociates you from the pain. Say, oh yeah, groovy, my pain is still there, but it's really not bothering me. Let's go find some more Cheetos. It's not clear that it does that. It doesn't do anything to the damaged nerves out here. If it's doing anything, it's working on the brain. Again, it's one of those things that probably can't hurt you very much. In Maryland, you can apply for a Maryland Cannabis Commission card. It takes 4 to 6 weeks, so if you better start now if you want to get one by the spring. And then your doctor or somebody can certify you. I certify people all the time, but I have to have an honest to goodness physician relationship with somebody before I can certify them.
And also too, Dr. Smith, I know one of my group members had used a salve that was a lot of THC. So she would just rub it on her feet and her hands, and that gave her such great relief.
It may well work. There is one published study about THC cream, and it's a mixture of THC and CBD, and it was supported by the company that made the product, which is always a little suspicious, and it didn't work for everybody. what I tell people about cannabis is it probably helps 1 out of 3 people. 1 out of 3 people with nausea, 1 out of 3 people with sleep disorders. Actually, maybe better than that for anxiety and sleep. Main side effects in people who haven't used it or haven't used it for a long time are anxiety and palpitations. I would add a third one for us old folks. That would be spraining your wrist or knee, going down on the floor trying to find your old Moody Blues albums. But
Okay.
just
I'm
be
going to ask
afraid if you start it that anxiety and palpitations are the main things, and that's the reason why people stop it.
Okay. Someone also asked, can neuropathy happen during monoclonal immunotherapies? And will these methods like cold therapy work too?
I'm not sure that cold therapy actually works at all. At least I'm not. My friends at the Mayo Clinic did this really well designed study, really hoping that it would work, and it didn't. There was no difference between the groups at all. Most immunotherapies leave your nerves alone. I mean, they can attack anything else, but they leave your nerves alone. Chances are, if you develop neuropathy while you're on immune therapy, it's probably a delayed effect from the last chemotherapy you were on, like oxaliplatin or Taxol or Taxotere or carboplatin. It's probably a delayed effect from that rather than something that's being brought on by the immunotherapy. One thing about immunotherapy, you actually want some side effects from it. People who get no side effects from immunotherapy, their immune system probably hasn't been stimulated enough. So it's when people get a rash, I say, yay. It tells me your immune system's working against something. The most common things to think about are rash, trouble breathing because of inflammation in the lungs, so cough, shortness of breath, and diarrhea. Those things can be life-threatening, particularly the lung problems and the diarrhea. So if you're on immunotherapy and you get a bad rash, you get trouble breathing or coughing, and you get diarrhea, please call your doctor right away, because you should probably stop the immunotherapy temporarily and get a whopping dose of steroids to nip it in the bud.
Okay. And I know a lot of people are asking for your contact information because they can't view it or copy it, but I will send it in an email, so don't worry about that. So the next question is electroacupuncture similar to scrambler therapy, and which do you think is better?
There are no comparison trials. The problem with electroacupuncture is you have no earthly idea what sort of current they're putting in there or what sort of signal you're putting in there. There are a whole bunch of companies that make these electroacupuncture, and I don't know what that signal looks like. I mean, the scrambler therapy was specifically designed to capture your nerve fibers and specifically designed to look like how one nerve talked to another. I don't know how these electroacupuncture things were brought about. It does seem to work. It probably works better than regular acupuncture. And again, it's not going to be harmful. Whatever current they put in there is going to be tiny, 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 tiny.
Okay. And so this is a little bit of a longer question. What if you have numbness in your feet that happened because of cancer lesions on your spine before you even started the chemo treatment and now persist well after the chemo treatment? Do you have data that shows scrambler therapy works for this?
It's probably not going to work for that. If the cancer was pressing on your spinal cord and damaged, what happens is it damages the blood supply to the spinal cord, and a little part of the spinal cord dies, leaving you with numbness and tingling, or even worse, some muscle deficits, motor deficits. That's not going to come back. You would just want to preserve it for what it is. So if you have those things, those are bad, but it's not the end of the world. What you absolutely want to do is keep the rest of your muscles working. Make sure you stretch your feet out. What you don't want is your foot to flap down like this. So you've got to make sure you stretch your Achilles tendon by putting a towel around, and your physical therapist should show you those exercises to do. You want to preserve what you have and adapt to it rather than try something that isn't going to work.
Okay.
That said, I haven't tried anybody with spinal cord injuries yet. I've got a couple people that we're working with Kennedy Krieger to see if we can do some good for that. But just thinking about it, I don't think it's going to work. I see people who have had this numbness and tingling for years, and it goes away in 15 or 20 minutes, or it gets substantially better in 15 or 20 minutes. I can guarantee you we did not regrow their nerves in 15 or 20 minutes. I mean, we are not salamanders that if you cut off their tail, they can grow a new one, or a leg, they can grow a new one. What I think is happening is people who have numbness and tingling have some normal nerves there too. Their signal is getting drowned out by all these damaged nerve signals. And if we can just turn that switch to turn those damaged nerve signals off for an hour, then the normal nerve signals can get up to the brain so people can say, you know, I can feel the floor. It's actually cold. I haven't been able to feel the floor for, 4 years now. So.
Great, thanks. Somebody asked, did you say ALA, alpha lipoic acid, will make neuropathy worse?
It could potentially make chemotherapy neuropathy worse. In the randomized trial, it didn't make it any better compared to placebo. And acetylcarnitine, the group that got placebo had less neuropathy than the group that got the acetylcarnitine. That did appear to make it worse. And that's been one of the frustrating things, is that some things like ALA, alpha-linolenic acid, that work in diabetic neuropathy a little bit, don't work at all with this because it's a different mechanism of nerve damage. All nerve damage is not the same.
And people want to know, are you accepting new patients?
I am way overbooked, and I'm trying to train some new people. I don't think I can take any more new scrambler patients because I have a list of about six months already. It's very time consuming, and I still have to write all my notes from the patients I saw this afternoon. But if you keep asking your doctors about it and say, this sounds really exciting, maybe they'll, go get trained.
Oh, that would be wonderful. Okay, so last question. And we are going to have access to this recording. Everybody will, so that's going to be available. And the last question is, how often do you apply the mineral ice?
Twice a day.
Twice a day.
Or you can do it 3 times a day. So first thing in the morning when you get up, after you shower in the morning, put it on then. It can't hurt to put it on in the middle of the day too. When Marie did her studies, her patients did it twice a day, so she did it twice a day in her studies, but maybe 3 times a day is even better.
Okay. And then just one last question about the compound. Is that something people would email you for, and you would write the script for that?
I can't write the script because I'm not your doctor, but what I can do is send you the recipe, and you can I'll send you the recipe, and if you want, send you the article showing that it actually worked, and you can go in and beat your oncologist about the head with it.
And then someone's oncologist can write the script.
They can write the prescription.
Right. Okay.
That's real easy.
That's great. Okay.
And it's not great, but it's better than nothing. And frankly, if it made me so that I could write better, or that I didn't drop my favorite mug, I would be pleased as punch.
Well, I think so many of us would agree with that as well. And Dr. Smith, we just cannot thank you enough for your time and for all this wonderful, important information. This is just really so spectacular. I'm just so grateful to you, and I know all of us here are as well. So this was excellent. So thank you very much. Just reading some things in the chat, but really just we don't oftentimes get this kind of information on a topic that is just so important and that so many of us are experiencing. So somebody just wrote, what a dedicated doctor.
Well, thank you.
I agree. So thank you so much. Thank you all
Okay.
for being here tonight. We've recorded this program, so it will be available. I'm going to ask everybody to, please fill out an evaluation. That just helps Hope Connections, with our programming, and the recording will be available as soon as we just edit a few things. So thank you again, everybody. Have a good night. And thank you so, so much, Dr. Smith.
You're very welcome. Good to see you all.
Okay. Bye, everybody. Good night.